This is a recent cover of the Time magazine, which was printed on the occasion of one of the largest cardiology meetings in the world. And in my mind, it really poses the right question: how to stop a heart attack before it happens. And I think this task and this question is really what treatment of diabetic patients is mostly about. Still 2/3 of our patients die from cardiovascular complications, and we are really in need of initiating early treatment strategies to prevent these disastrous complications in many of our patients. Next slide, please. This is the projections of the diabetes development projections done by the WHO, and the WHO really classifies diabetes as an epidemic, and diabetes is the only non-infectious disease which is classified as an epidemic by the WHO. So these are the projections for the year 2025, and there's a dramatic increase all over the world. And next, please. These are the numbers which are based on known diabetic cases today, but I think it's very fair to add really approximately 50% to these numbers, because we have a very large proportion of subjects living in our societies who are diabetic but haven't diagnosed with diabetes yet, because it is a silent disease. It is frequently just not tested, and for many years, even decades, it remains unknown and is in this period especially very harmful to the body. Next slide. It shows you here what we call the Diabetes Continuum, the cardiovascular enemy attacks, and this enemy really attacks very early on, not just with the diagnosis of diabetes. It starts way ahead, and in the phase of IGT, impaired glucose tolerance, and insulin resistance, you already have early impairments of the vascular function. So I would like to give you some insights about this association between dysglycemia and vascular alterations. And one of the key pathophysiological elements which we are understanding more and more about is really postprandial blood glucose, and this is data from the DECODE study, which presents here impressively that postprandial blood glucose is much more associated with the risk for myocardial infarction than preprandial blood glucose. It's really the postprandial spikes, the increase in blood glucose, which elevate this vascular risk. And the DECODE study is only one example of many of the trials which have looked into this matter and have really confirmed the association between postprandial blood glucose and cardiovascular mortality, such as the Honolulu Heart Program or the Rancho Bernardo study, Whitehall Paris prospective trial. So there's really numerous clinical data which is emphasizing this association. And I would like to give you some insights about the mechanistical problems which occur in this regard. And this is data from a meta-analysis which looked at the association again, and you see the mean blood glucose, the postprandial blood glucose, and the upper and lower confidence interval. And what you see from this meta-analysis, which included more than 100,000 subjects, is really two things. First, that there is no threshold for this association, so there is not really a cut-off level where you can say, well, when blood glucose is beyond this threshold, we don't have a problem. It really starts very early on, so it's a continuous relationship, and the risk extends far beyond the diabetic threshold. It's already present in IGT, it's already present in the upper normal range of postprandial blood glucose values. And this is a study which really illustrates how postprandial blood glucose and vascular dysfunction are associated. In this investigation, really three groups of subjects were included: NGT with normal glycemic values, IGT, impaired glucose tolerance, and diabetic subjects. And one performed an oral glucose tolerance test, and you see here the plasma glucose levels. That's very much what you would expect in these three groups of subjects. And in parallel, one looked at endothelial-mediated vasodilatation. One looked at flow-mediated dilatation of the brachial artery, so as an early indicator of vascular alterations. And it's very interesting to see that already in normal subjects, this postprandial blood glucose elevation is associated with a paradoxical decrease of blood flow, and it returns to normal after a while in the NGT group. But in IGT and diabetes, this paradoxical vasoconstriction is really further enhanced, and in diabetic patients it doesn't return or doesn't even show a tendency towards normalization. If you plot the single blood glucose values together with the degree of flow-mediated vasodilatation, you get a very strong correlation. So it's a single blood glucose value which is correlated with the degree of vascular dysfunction. Very impressive data in my mind, and one looked a little bit more into details, and the question was really, what could be the mechanism behind this association of postprandial blood glucose increment and postprandial paradoxical vasoconstriction. And it's really the oxidative stress which comes up here and which plays a role, and markers of oxidative stress were measured. And if you really look at plasma glucose levels in this study and see the association with the degree of oxidative stress, you find a key phenomenon which is responsible for this association, and it's really largely mediated via oxidative stress. And we in Munich, we also look at the diabetic heart, and this is nuclear imaging techniques which we apply, and we look at myocardial blood flow. And we can actually quantify it and present the blood flow as you see here in polar coordinate maps. And this really enables us to look at several regions of the heart separately. This is the anterior region, this is the apical region, and this is the posterior region. And what happens in the tests which we perform, and this is a test, this is a cold pressure test to as a stimulus for endothelial function, you see really that the blood flow increases. It increases in normal subjects and also in type 2 patients without endothelial dysfunction. And the next slide shows how different the situation can be in many of our patients who do not show any signs of clinical coronary artery disease yet, but they have a paradoxical vasoconstriction. So here you see really the myocardial blood flow, which is firstly elevated at rest in these patients, and then you see the paradoxical vasoconstriction in response to this cold pressure test. Approximately 40% of diabetic patients exhibit these early signs of vascular dysfunction. And looking at metabolic control and risk for cardiovascular disease, and also in view of treatment options, I find this data here very interesting. It actually shows the continuous glucose readings of type 2 diabetic patients. So it's a 24-hour glucose monitoring. This is the mean here, and the mean plus standard deviation and minus standard deviation. So a very profile with significant fluctuations. It's not a flat line you see here. And with the advanced techniques, you can actually measure and quantify these blood glucose excursions. And this is called MAGE, mean amplitude of glycemic excursions. So this is really the ups and downs of blood glucose. And if you really quantify this MAGE, you again see a very strong correlation with oxidative stress, which is so much responsible for the cardiovascular affection. And in this study, one also looked at other markers, markers we use in the everyday clinical practice for looking at blood glucose control. And if you compare the level of oxidative stress with HbA1c, for example, you don't see a correlation. Very interesting data. Even if you look at mean glucose, you don't see a correlation. But if you correlate it with postprandial blood glucose, you see a significant association, and also a significant association with the mean amplitude of glycemic excursions. So the picture we have and is really changing, and we should keep this in mind when we treat our patients. It is HbA1c is certainly the gold standard we are using for many of our patients, but HbA1c really doesn't reflect the blood glucose excursions or the postprandial blood glucose values, which are more significant with regard to the occurrence of cardiovascular complications than, for example, the mean glucose. Next slide, please. And this is a slide which looks at our daily life, and it is to illustrate to you that we spend most of the time in the postprandial periods, in the postprandial and post-absorptive states here, and there's a significant overlap between breakfast, lunch, and dinner, and it's really a very short term we spend in the preprandial state. The lifestyle changes, the frequent intake of high-calorie meals really leads to this association. And this is the next slide here. which is shown and which takes up the topic again, preprandial and postprandial blood glucose. And it really looks at the composition of the HbA1c and the contribution of postprandial and preprandial blood glucose. So if you have very high HbA1c levels, 10, 11, 12, it's really largely the preprandial blood glucose which contributes. But look please, if the HbA1c improves, so if you move to the left side of this graph, the situation really turns around. And if you have HbA1c levels around 8%, 7.5, it's really the postprandial blood glucose which matters and which contributes. I think it's just good to keep this in mind. So when we treat patients, for example, with HbA1c levels of 8, and we want to improve further, towards 7.5, 7, we should really look at the postprandial increments for further optimization. And this concept of postprandial blood glucose really will be represented in the new guidelines, the ESC, this is the European Society of Cardiology, and the EASD, the European Diabetes Association guidelines, joint guidelines, which will be published hopefully this year in these two journals, Diabetologia and European Heart Journal. And the recommendation is really here on postprandial blood glucose, which provides better information about future risk for cardiovascular disease than fasting glucose at a very high evidence level, class 1, level A, and the recommendation to really treat postprandial blood glucose and with beneficial effects on cardiovascular risk and mortality. So we have very good evidence about the association of post-load glucose and cardiovascular disease. And this is another key slide of these very new guidelines, and it emphasizes the joint or the parallel occurrence of coronary artery disease and diabetes, and it really gives the recommendation that in all patients with coronary artery disease, one should look at glucose metabolism and perform an oral glucose tolerance test for diagnosing diabetes. There's data which shows that up to 2/3 of patients with coronary artery disease have silent diabetes. Diabetes which just has not been detected in the past. And having these pathophysiological aspects in mind, I would like to draw your attention to acarbose, to glucobi, which really delays the absorption of carbohydrates. And this is shown here, that with acarbose you really have a delay in the absorption and also a prolongation of the absorption of carbohydrates, and this translates into a flattening of the postprandial blood glucose elevation, as shown here, really a flattening which is due to this delay in absorption. However, I should also mention that other effects have been reported for acarbose in this regard. There's a multitude of gut hormones which are influenced by acarbose, such as GLP-1 levels, for example, which have been shown to increase with acarbose and which are severely reduced in the diabetic patient group. And some study which really underline the concept, this is a a placebo investigation, placebo versus acarbose in non-diabetic subjects. And you see the significant reduction of post-meal elevation of blood glucose with the administration of acarbose. And really there are numerous studies which look at impaired glucose tolerance with acarbose, the pre-diabetes state, and we estimate that approximately 60 to 70% of IGT patients really convert to diabetes within 5 years. And this is data of a 4-month placebo-controlled trial which showed that in IGT subjects, really the plasma glucose levels were reduced with acarbose, and this was accompanied subjects. It's really the steady state of plasma glucose which was reduced and which did not change, certainly in the placebo group. This is really an elegant investigation which proves the concept which I have been introducing to you. And here you see again the placebo elevation of blood glucose and the blunting with acarbose in IGT subjects. And in parallel, one looked at flow-mediated vasodilatation of the forearm, as in the previous study which I have been showing to you. And very interesting, the effect. You see the paradoxical vasoconstriction with placebo, but in the acarbose group, this decrease in blood flow is completely prevented. Yeah? In this early phase of diabetes. So very interesting data how an improvement of postprandial blood glucose can really prevent vascular dysfunction in IGT. And there are interesting studies which look at the mechanisms and the effects in a more detailed level. Here a study on NF-kappa B activation, and a study which really looked at the mitochondrial level, and NF-kappa B activation is a phenomenon of type 2 diabetic patients, and it's largely responsible for activation of other pathways such as polyol pathway, production of advanced glycation end products, and hexosamin pathway, for example. And with administration of NF-kappa B, you can actually reduce, with administration of acarbose, you can actually reduce the NF-kappa B activation in diabetic patients. Also, there's data which shows a reduction of inflammatory markers in IGT and diabetic patients, for example, CRP levels. Looking at the clinical data, I would like to present to you the STOP NIDDM study, which was performed in IGT subjects and which really compared a 3-year administration of acarbose versus placebo. And one certainly looked at the conversion rate to diabetes, but also at the cardiovascular outcome in this study. And the next slide shows you the study population and the design of the study. More than 1,400 patients were randomized, either allocated to acarbose or placebo, and more than 680 subjects with IGT were included in each arm of the study. And here you see the outcome with regard to the presence of diabetes. And it was seen remember, all patients had IGT at inclusion into the study, and the conversion rate from IGT to diabetes was much slower in the acarbose group as compared to the placebo group. Approximately a 1/3 reduction of occurrence of diabetes was seen with acarbose, and the other aspect is that the reversion from IGT to NGT was more enhanced in the acarbose group as compared with placebo. So not only a delay in progression was seen in many patients, but also a reversal of dysglycemia was seen in the subjects. And the next slide shows you the cardiovascular aspects which were evaluated, a composite of major cardiovascular events, really, myocardial infarction, revascularization procedures, but also cardiovascular deaths, cerebrovascular and peripheral vascular disease was included. And the results of the cardiovascular outcome are summarized here in this slide, which really shows that here is the acarbose group, this is the placebo group, which really shows that acarbose prevented the occurrence of myocardial infarction, actually up to 91% in this study, and also the occurrence of any cardiovascular event was significantly reduced in the acarbose group, and this is shown here in these curves, which really show you the cumulative incidence of first cardiovascular events with the placebo group and with the acarbose administration. And very interesting to see that especially in the long-term follow-up, some patients were followed up to 5 years, even longer, the differences are most prominent. The next slide also emphasizes one aspect which is a problem in diabetes. It's silent myocardial ischemia due to autonomic neuropathy. Diabetic patients frequently just don't have symptoms, which are typical in non-diabetic subjects for myocardial infarction. They don't feel chest pain, they don't feel cardiac disturbances so well, so there is a high frequency of silent myocardial infarction in diabetic patients. And if you add these silent myocardial infarctions, which were really diagnosed with ECGs, and cardiologists looked at the ECGs, and if you add the silent myocardial infarctions to the clinical myocardial infarction, the reduction even becomes more prominent, 2 cases versus 19 cases in the placebo group. Also, effects on blood pressure have been reported in the STOP NIDDM study, which showed that the reduction of systolic blood pressure and the reduction of diastolic blood pressure is really more enhanced in the acarbose group and significantly different from the placebo group. And here the reduction rates which were achieved with acarbose, also new onset hypertension was reduced by 34% in the acarbose group. I showed you the data on myocardial infarction reduction, 91%, and any cardiovascular event was reduced nearly up to 49%. Well, these were data on IGT subjects, the Stop NIDDM study, which really looked at dysglycemia and cardiovascular outcome. And the question is really, does this translate to diabetes? What is the effect we see in diabetic subjects? Do they have also a benefit with regard to the cardiovascular outcome? And here I show you data of the MIRIA analysis, which included the 7 double-blind, randomized, placebo-controlled trials. More than 2,000 patients were included, and the mean treatment period was more than 400 days in each of these groups. And the cardiovascular profile, the clinical characteristics, just to show this to you, was very comparable between the two groups. If you look at cardiovascular disease, no significant differences. Hypertension, here chronic cardiac ischemia, heart failure, myocardial infarction, and cerebrovascular disease. Very comparable clinical characteristics at entry into the studies. And when you look at the cardiovascular outcome, it is very interesting to see that the data and the results resemble very much the ones I've showed you previously for IGT. There is a significant reduction in the occurrence of myocardial infarction with acarbose, and also a significant reduction of any cardiovascular event. Very comparable results were seen, and this slide summarizes the cardiovascular outcome data. Any cardiovascular event was reduced by 35%, and myocardial infarction was reduced by 64% in the type 2 diabetic patients. So coming from these studies, the large clinical investigations, but also the numerous investigations which looked at mechanisms and beneficial effects with regards to postprandial blood glucose control and factors such as endothelial function, where do I see the role for glucose in the diabetes continuum? Certainly, with regard to the very positive results in IGT subjects, not only the beneficial effects on dysglycemia and conversion to diabetes, but also due to the beneficial effects of cardiovascular outcome, it's certainly a very good partner for treatment of IGT and early diabetes. And we use it also many times as a monotherapy, as a first treatment approach for subjects which are at high risk for type 2 diabetes, which have IGT, or which have newly detected type 2 diabetes. The advantage we really see is the benefit on the postprandial blood glucose, the benefit on metabolic control, but also it is the only oral anti-diabetic agent which really has shown the superiority with regard to cardiovascular outcome. We have the good data from IGT, and we have the good data from type 2 diabetic patients. And also one very advantageous profile of acarbose is certainly that it is free from any severe side effects. So it is a safe drug for patients whom you do not see so often. You do not have to monitor, for example, kidney function. You do not have to monitor liver function, and also you don't have to worry about heart failure or edema, increased fluid retention. So this, in my mind, really are arguments for the use also in the early phase of diabetes. And I should also mention that, for example, severe hypoglycemias, which are seen, for example, with the sulfonylureas, cannot occur with acarbose, and these are aspects which we consider when we treat our patients. So for monotherapy, a very good partner, and then also for combination approaches with other oral anti-diabetic agents. We have just completed a study also which looked at newly initiated insulin therapy in type 2 diabetic patients, and the potential benefit of additional acarbose administration, and we saw a very good benefit, especially with regard to the absence of weight gain. So the weight gain which we saw in insulin-treated type 2 diabetic patients was not present with the additional administration of acarbose, and the effect of metabolic improvement was also stronger in the combination of insulin plus acarbose. So let me summarize the aspects I have tried to highlight to you. Certainly the postprandial blood glucose, which elevates or which enhances the vascular risk, and a key factor is the oxidative stress, which leads to multiple abnormalities of vascular dysfunction. So this is also part of the new guidelines. Targeting postprandial hyperglycemia really decreases the risk for vascular dysfunction. And with regard to postprandial blood glucose, I have showed you the data of the improvement of postprandial excursions and improvements of metabolic control. And the effects of acarbose are seen across the diabetes continuum. So if we focus on cardiovascular disease in IGT and diabetes, it really targets a multitude of key factors leading to vascular abnormalities in impaired glucose tolerance and in diabetes, and acarbose has been shown to prevent myocardial infarction and cardiovascular events, both in individuals with IGT, the STOP NIDDM trial, and in patients with diabetes, the MIRIA investigation. Yes, this was the overview of the importance of postprandial blood glucose with regard to the occurrence of complications. But in my view, and the data we have today is very good. We have with Glucobay a very good approach, really, to target postprandial blood glucose and the consequences which are associated with the mean amplitude of glucose excursions, which can be significantly reduced. Thank you very much for your kind attention.